Amigos de Perio MX, seguidores todos, aquí estamos en el stand de Strongman, aquí en el Congreso del ITI en la Ribera Maya con el doctor Stephen Chen. Stephen, thank you very much.
It's a pleasure.
Welcome to Mexico and to Cancún.
Thank you.
Y bueno, pues estamos platicando con el doctor Stephen, escuchamos al doctor Stephen toda la mañana. We're listening to you about hot topics in implantology and three only questions. Yes. First of all, implantology is for all the dentists in the world, because here in this meeting we have orthodontists that put implants, endodontists that put implants, periodontists and periodontologists that put implants. Everywhere, everybody wants to put implants. Well, implantology is I think that it could be a problem. But what is your point of view?
That's a very interesting question, because as you know, when implantology first began, it was within the specialist group, and in fact it started with maxillofacial surgeons first, and then gradually periodontists became involved, and other specialties that had some surgery in their training. But like all new technologies, eventually with the rise and the popularity of these techniques, eventually more and more general practitioners will also want to get involved with implants. But not only that, other specialties who see themselves as having some interest may also want to do implantology. I don't think we can necessarily say implants are only confined to surgeons or only confined to periodontists. But if there are prosthodontists, endodontists who are interested, I see no problems with that, unless they don't have the proper training and the education. I think that is the issue. It's not who does it, but if you are going to do these procedures, are you properly trained and educated? And that's the big dilemma that's facing us today, because many situations are our colleagues don't receive the right education. They do short courses, intense courses, and the courses are designed of how to do, but not why to do, and not where to do, and most importantly, Carlos, when not to do. That's the part that education provides for our colleagues. So the ITI, of course, is very much focused on the educational side. So when you ask, this is the long answer, you ask me that question, is it for everybody? I'll say, well, no, it's not for everybody, and it shouldn't be for everybody. But those who want to do it have to do it in a responsible way.
But ITI is for everybody.
Of course, anybody who's interested in implantology. And you can belong to the ITI and never surgically place an implant. You may only be interested in the restorative side of implants. That's fine. Or you may not even be interested in doing any of the clinical procedures, but you're just interested in the technology and the techniques and the evidence behind it. So of course, implants today are part of normal dentistry. How can you say endodontics is not for everybody? But then I ask you, how many general practitioners do endodontics? Many of them choose not to do endodontics. They want to do orthodontics, but many general practitioners don't do orthodontics. So, you know, we all in our practices decide what we like to do eventually, and then we focus on those things we are good at. We cannot be good at everything. But if you want to do implant surgery, then you must make sure that you have proper training and education.
That's why young students may have an implant concepts in his first of all elementary concepts and in the classes, like first years. I think that maybe and that it's best with us at the university. We teach periodontal tissues. Well, we teach for today peri-implant tissues. For students, for 20 years students.
Yes.
What are your hopes?
Yeah, of course. Because implantology is now mainstream dentistry, it should be included in the curriculum. But then each university has to decide how much implantology to teach, because you have a certain amount in your curriculum. If you put more implants, then you have to pull something out. So what do you stop teaching? So that is always the challenge in any dental undergraduate program. Of course, when you get to postgraduate or graduate study, then you are choosing an area of your interest. Then you can spend a lot more time in this. But I think dental schools at least must introduce the concepts of implantology and explain how implants fit into general dental management and replacement of teeth, so that our young graduates leave understanding the role of implants in dentistry as a whole. They don't have to know the specifics.
No.
Just like they need to know where endodontics fits in, where crown and bridge fits in, where orthodontics fits in.
the next question is about periodontics, because we know that you're a periodontist.
Yes.
And this question we asked we talked with Anton Schoon, and we talked with Giovanni Zucchelli, and right now here, if you have an intramoni defect it's a clinical situation.
Yeah.
If you have an intramoni defect with what you put, membrane with bone graft, membrane with emdogain, membrane, emdogain, and bone graft. What's your opinion about it?
Well, I think in terms of regeneration, the biomimetic approach using enamel matrix protein or enamel matrix derivatives, emdogain, I think is biologically very sound. But like all regenerative procedures, we are limited by maintaining the space. So the use of a grafting material in conjunction with emdogain, the use of a membrane in conjunction with emdogain is only there to help maintain the space. So you have to understand the defect morphology, and you have to understand what happens when the flap is closed and how much it tends to collapse. Because if you have a nice narrow defect, you can get beautiful regeneration all by itself. But if you have one wall missing and it's a broad wall, then you may want to put a graft in to support it. So I don't think it's a question of what do you do. For me, as you saw in my lectures, it's what do I do for that clinical case. Because every case has to be assessed independently and the treatment plan developed that fits and suits that clinical situation. So not one approach fits everybody.
It's very intelligent answer, because every patient have a different.
Every patient is different, and even in the same patient, you may have different types of bone defects.
So we read a lot maintenance. Maintenance is a hot topic in periodontology and implant dentistry.
Yes, of course.
So what's your opinion about hygienic strategies like electrical toothbrushes, manual toothbrushes? What's your opinion about it?
My opinion is whatever the patient can use to remove enough plaque on a daily basis to maintain periodontal health, that's good enough for me. Give you an example, Carlos. I have some patients who are low periodontal risk. They don't floss their teeth every day. They never get chronic periodontitis. They never even get gingivitis. So if I stand there and tell them you have to floss your teeth every day, they're going to look at me and say, why? On the other hand, you have some patients who are so susceptible, if they don't floss twice a day, you're going to get gingival inflammation, or they use interdental brushes. If they don't see you for maintenance every 3 months, you can see them breaking down. So I think once again, this is what they call in medicine. It's patient focused. So every patient has to have an individual treatment plan developed for the individual. And when it comes to maintenance and plaque control and periodontitis, same thing. It's how much of a risk are those patients, and then you develop a plan. Because what's the point of telling someone they have to do flossing or interdental brushes and come to maintenance every 3 months where they are not at risk of developing periodontitis? It doesn't make any sense.
Yeah.
So again, the same principle applies, that it's case by case treatment planning. And you know what? Eventually, what it's about? It's understanding risk. So when you come in and you see your practitioner, your medical colleagues, what do? They look at your family history. Do you have diabetes in your family?
Yeah.
Do you have anyone had a heart attack in your family? Do you have cholesterol families? So your physician is building up an image of your risk profile. Of course, there are certain tests that they can do, blood tests and so on, blood pressure. So we can then develop a risk profile. So we can say, okay, Carlos, when you're 40, maybe you have to start thinking about cholesterol. When you're 50, maybe we have to start doing certain tests and exams. Maybe you have to start putting in statins. So they are all looking at risk profiles. And in dentistry, we should be doing the same. Our patients come to see us, we try and establish what's their risk profile. What are the two major dental pathology? Caries and periodontitis. That's all we really have to look after, right, as dentists. So what is their caries risk profile? What is their periodontal risk profile? And once we understand that, then we can customize their care to suit those individuals. And patients who have chronic periodontitis, for example, we know they're at much greater risk. And they also have greater risk of developing peri-implantitis. We know this. The risk is 4 to 5 times greater. So they have to understand what their risk is if they want to go ahead with dental implants. They need to understand that they need to have their teeth and implants maintained as well, as a lifelong commitment to their oral health.
And talking about diagnosis, what do you prefer for examination of the peri-implant sulcus? A plastic probe or metallic probe?
I think it makes no difference.
No difference.
No difference at all. Important, it's a fine probe. It's not a fat probe, thick probe. You
Yeah.
can have thick plastic, thick metal. So for me, it really doesn't matter so much. We know that the epithelial barrier will heal itself, and your risk of scratching the titanium is really very low. So I would rather that our colleagues actually do an examination. So if they have a nice fine periodontal probe with a plastic or metal, I think it's fine.
And as our president in the ITI and as a colleague, a periodontist, what is your expectation for a new classification of periodontal disease?
This is the recent World Workshop. Yeah, they are looking. They are looking at changing the way in which diseases are classified. It's quite a radical approach. It follows the medical model. That it is quite a different change to what we are used to seeing. It follows much more closely to the medical model.
And last question about your lecture that we will listen very carefully. In type 2, in the implant placement type 2, it's not necessarily a connective tissue graft. You put only a collagen sponge.
So I can tell you, as a periodontist, I used to do a lot of connective tissue grafts.
Yeah, me too.
Especially when I do immediate implants, because you have to thicken the tissue. Today, when I adopt a type 2 approach, because of the spontaneous thickening, and then gain in soft tissue height, as I demonstrated to you, and not just clinically, but we have data to show this. And if I've done a graft to augment the thickness of the bone, I almost never need to use a connective tissue graft.
Okay.
Almost never need to do it. Very rarely do I have to add soft tissue. And I usually see this when I close the flap, and if I think, it's collapsing a little bit too much, if I cannot add more biomaterial, then I might add some connective tissue.
Because you increase the volume with a sponge only.
Yes.
And the morbidity for the palate doesn't exist.
Doesn't exist anymore, yeah. And yes, so I think that's one of the other advantages of the type 2 approach, because of the spontaneous thickening of the soft tissue. Thin phenotype turns into thick phenotype if you give it enough time. And then that has great advantage for us clinically. Also, when you want to close the flaps and you want to advance, you don't have to advance the flap so far. And there's therefore less morbidity to the patient. Your periosteal release can be just release the periosteum without going too deep into the tissues, into the muscle layer. So it has
it's a good thesis. Yeah. So, and for the molar, we take very fond with the position for the molars situation, like you are as a patient. But what is your recommendation for the molars? So it could be in implant placement, type 2 or type 3,
well, normally,
type 4, because type 4 is not.
Well, normally for molar teeth, I adopt a type 3 approach because it's a larger socket. More bone to heal, and my intention is to have enough bone to have the implant with primary stability. And if there are any minor defects, then you can graft around the defects. So I would usually, and I say usually because it does alter from case to case, but predominantly in multi-rooted teeth, I will adopt a type 3 approach because my primary objective, the biological outcome that I want with healing, is enough bone to have primary stability on the implant.
Okay. So, thank you very much, Stephen.
Carlos,
thank you very much. Bueno, pues gracias al doctor Stephen Chen. Estamos aquí en el Congreso del ITI en la Riviera Maya. Thank you, Stephen.
Muchas gracias.
Muchas gracias. Y bueno, pues viva Australia.
Oh, viva Australia. Very good.
Thank you very much. Bye. Thank you.